Nag-testing na kami ngayon. Hindi, baka may default na kami. Oo, eh, ano mo rin naman ako. Panahin ko, ma'am?
Sir, wag mo ko Checky, hey. Sound check. Sound check. 1, 1, 2. Sound check. Sound check. Checky, hey. Check. 1, 1, 2. Sound check.
MCCOD.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 2 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health, and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 2 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health, and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health, and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Test mic. Test mic. Test mic. 1, 2, 3. Test mic.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course is offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 150 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health, and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 150 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health, and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health, and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health, and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health, and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health, and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 2 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health, and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 2 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health, and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 150 every 2 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Check, hey, check.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 150 every 2 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 150 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 150 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Using the online platform, we hope to enroll all of our senior clerks to the MCCOD program in July 2021. We have had the experience of scale with our senior clerks this school year, and we hope to replicate the same success in the incoming academic year with our experienced and dedicated faculty.
Correct death certification results in important mortality data used to inform public health and social development investments of the country. Yet, despite it being a routine professional activity, mortality data is challenged with issues of poor quality, inaccuracy, and incompleteness.
This is a web-based education program for medical students, postgraduate interns, and licensed physicians. It was very timely because universities are forced to transition from face-to-face to e-learning online as a result of the COVID-19 pandemic.
MCCOD instructional design helps the faculty in teaching the course by increasing awareness of the medical students on the significance of a correct and completed MCCOD in improving data statistics as a basis for healthcare planning and programming. The instructional design helps in teaching a correct MCCOD that follows a logical progression or sequence of disease processes. And finally, in preparing medical students to proper and complete filling out of the MCCOD.
The blended learning course was offered to all our 186 clinical clerks this academic year for 8 months. We conducted 30 small group discussions in total, around 1 to 3 every 3 weeks. We plan to continue implementing the MCCOD course during clinical clerkship in family and community health and to offer it to our UP Philippine General Hospital medical interns and residents and fellows in training.
Today, today is the birthday of Deputy National Statistician Fred Soliesta. Happy birthday. We will start in a few minutes, so I request everyone to stay on your seats.
Good morning, everyone. Hello. I hope you guys were able to rest last night. And welcome to our second day. Thank you so much. It's lovely to see everyone here again. I'm just here, not taking over Doc Lisa. I'm just here for some reminders. So I'm reminding everyone that we are also going live on Facebook. So if you have friends, you may message them to visit crvs.doh.gov.ph. We are also live on YouTube, and we encourage our virtual audience to also participate in our discussions. So you may type in your questions in the comment section, and our discussants and panelists would be happy to answer those. So I hope you guys have a good morning. And Doc Lisa, over to you. Good morning, everyone.
Thank you very much, Kling. So good morning, everyone. This is day 2 and our final day of the National Civil Registration Vital Statistics Stakeholders Conference, reinforcing the Philippine Plan for Action for Civil Registration and Vital Statistics. I would like to report to you that yesterday, the first day of the conference, there were 150 of us on site, physically here, and 36 online. We welcome today's participants online. I would like to present the highlights of yesterday's conference. So yesterday we were presented with the objectives of this conference, which are to present the 2022 Comprehensive CRVS Assessment Report results, including high impact and high level issues and recommendations, and identify key action areas to actualize the CRVS National Plan of Action. We heard from the organizers, the heads of the organizers. Dr. Graham Harrison of the World Health Organization of the Philippines underscored the importance of multi-sectoral efforts and continued support of all partners in the success of the CRVS system in the Philippines. And this is why I emphasize that there were 150 of us on site yesterday representing various sectors of stakeholders for CRVS. Our Civil Registrar General, Undersecretary Claire Dennis Mapa of the Philippine Statistics Authority, stated the commitment of the PSA in looking for ways to better serve the Filipinos and highlighted its digitalization of CRVS system with three components. Component one, the implementing rules and regulations of Act 3735 or Administrative Order Number 1, Series of 1993, which will be reviewed and updated to have a legal framework. Component 2 involves the development of the enhanced Philippine Civil Registry Information System, or ePhilCRIS, and the linking of PhilSys, the Philippine National ID System, and CRVS. And lastly, the third component is the system digitalization for correction of errors, RA 9048 and RA 10172. OIC of Department of Health, Maria Rosario Vergeri, reported on the relentless campaign of DOH in improving mortality statistics, specifically on medical certification of cause of death. She stated that it is time that the Philippines use vital statistics from CRVS system as the source of information for national indicators as the Philippines plans for the monitoring midway into the Sustainable Development Goals and the last mile of the Civil Registration Vital Statistics Decade for Asia and the Pacific, and the crafting of the new Philippine Development Plan. We had 3 sessions yesterday. Session 1 was Getting Every Pinoy and Pinay in the Picture, which provided us with the initiatives to strengthen the CRVS system and specifically to meet the Philippines' targets for the Asian Pacific CRVS decade. And there were a number of action items that resulted from the presentation. And they are amendment of Act 3753, or the Law on Civil Status. Some of these have been mentioned by the CRG. Continuous improvements of the frontline services and updating of policy issuances. Intensify civil registration campaign on birth registration and other civil registry documents. Improvement on the quality of death statistics through capacity building, birth and death registration projects, especially in areas with low levels of registration, and digitalization of the Philippine CRVS system. So the session 1 reinforced what were mentioned by the partners, the heads of the organizers, the 3 partners organizing this conference. Sessions 2 and 3 are 2 of 6 action areas that resulted in the 2022 assessment of the Philippine CRVS system. Session 2 is boosting CRVS impact through legislation. There was a very active discussion on legislation and legal frameworks for CRVS. What struck to me was the comment of one of the discussants that says there are 3 legal frameworks that can be utilized to really provide impact legal frameworks for CRVS. These are an administrative order from the Civil Registrar General, an executive order from the Philippine President, and a law. And so his advice was for us stakeholders to discuss which ones do we do first. It is clear in my mind that the law, the amendment of our civil registry law enacted in 1930 needs already to be done, to be updated, and to provide the legal basis for the initiatives that we have, especially digitalization. But that was a comment that really was very important for me as one of the highlights. Another comment was that we are now actually talking about not just CRVS, but it's CRVS-IM, civil registration plus vital statistics plus identity management. And there were a number of action items that resulted in the discussion. I actually enumerated them already yesterday from the summary. We will be providing the list in our documentation for everyone who are interested. Session 3, leveraging opportunities to improve death certification, emphasized the importance of CRVS for health with focus on medical certification of cause of death. Our discussion really highlights the importance of CRVS on health. Of course, there are many sectors that CRVS system really has to address, which are the 3 goals of the Asia-Pacific CRVS decade. So providing legal identity to citizens, providing them with legal documents, and providing vital statistics. So a very important last mile for the Philippines, this is the improvement of cause of death statistics. And really vital to this is medical certification of cause of death. And there was a discussion on medical legal cases involved for MCCOD. So in my mind, these are some of the items that we have to look into. And so there were also a number of action items that resulted in the discussion, which we will enumerate in a documentation. I actually enumerated them yesterday. Today, we are going to have the last 4 sessions of action areas from the 2022 assessment, and we will follow our process yesterday, where our moderator, Dr. Portia Marcelo, will take charge of the sessions, and she will be introducing the resource speaker as well as the discussants and lead us to a very good active discussion in the open forum, which we will request the online participants to actively participate in through the online platform provided you. So, ladies and gentlemen, may I call on Dr. Portia Marcelo, our moderator for today. I introduced her yesterday, so maybe just important that she's a very good partner in the discussions on CRVS, especially MCCOD, professor of the University of the Philippines. Portia, please.
Okay. Good morning, everybody. I hope you had, again, a good rest and a good breakfast for this morning. Okay, so let's begin our session 4, translating data into evidence for decision making. And we are privileged to have, one of the champions really for collaboration, if you may, between the CRVS system and the health system. So together with Charity, I mean, these are the people that I've seen since forever. Miss Au Riolalas, fondly called Au, has been one of the pioneers of the Philippine Health Information Network. This is an interagency organization really getting the stakeholders actually together to first discuss what's happening with the information, the data that we are generating, and then how can we work together. Yesterday, CRG, Ericta said something about integrity, competence, and empathy. So Ma'am Au would really talk about living out these principles of integrity and competence in several of her papers on civil registration and vital statistics, always presented in different forums, such that she was a consultant of the UN Statistical Institute for the Asia and the Pacific region. Please welcome the Chief Statistical Specialist of the Vital Statistics Division, CR Civil Registration Service of the PSA, Ms. Au Talan Riolalas.
Good morning, everyone. I am pleased to present for session 4 on the topic translating data into evidence for decision making. So here's my outline of presentation. So I will give some introduction, uses of CRVS data, latest updates and statistics on births and deaths and by cause, challenges and issues, and ways forward. So the PSA was created through RA 10625 with the mission deliver relevant and reliable statistics, efficient civil registration services, and inclusive identification system for equitable development towards improved quality of life for all. In this slide, I cite only 2 functions among the many functions of PSA, which are as follows. Serve as a central statistical authority of the Philippine government on primary data collection and carry out, enforce, and administer civil registration functions in the country as provided for in Act 375P, the Law on Registry of Civil Status. As the central statistical authority, the system of designated statistics was established in 1996. By virtue of EP number 352, also known as Designation of Statistical Activities that will generate critical data for decision-making of the government and the private sector. So next slide, please. To identify and designate the most critical and essential statistics required for social and economic planning and analysis. Among the 67 designated statistics identified, vital statistics is one of them that is being generated for use in the decision-making of the government and private sector. Some of the indicators that can be generated from CRVS are birth and death statistics, and some mortality indicators such as infant mortality, neonatal mortality, under 5 mortality, and maternal mortality, to name a few. So before we continue, let me discuss first what are the importance of data. In this slide, I cited 8 importance of data, to name a few. So data empowers to make good decisions. Good data will give us justification and evidence we need to back up our decisions to make us confident explaining our reasons. Without solid data, more likely we will make mistakes and reach incorrect conclusions. Access to good data will ensure us to identify significant problems early and take actions to solve them. Data helps us identify short-term problems. It also provides the tools necessary to develop more accurate long-term theories. Data will back up arguments to come out with better decisions. Data tells us what we're doing well and what we're not doing well. Access to good data will help us improve the quality of life. So one of the data that we are talking about here in this conference is the CRVS data. Actually, the CRVS data that we are talking here is more on health, that is the data on birth and death statistics. Aside from the birth and death statistics, we have also marriage, legitimation, annulment, divorce, etc. That is also we generate in the CRVS. So there are advantages in using CRVS data, which can be summarized in 6 C's. These are continuous, consistent, comparable, complete, correct, and with cause of death. We say continuous because all vital events such as births, marriages, and deaths are registered and monitored as they occur. Since CRVS are permanent, the data they generate are not only available continuously, but also consistently over long periods, permitting the construction of historical time series. So meron tayong mga data na kung mapapansin niyo po sa aming website, meron tayong series of data ng mga vital statistics. So, meron kaming summary sa Vital Statistics Report, meron kaming summary doon na statistic starting from 1903. So, kung titingnan niyo po, meron tayong births, marriage, deaths, pati meron kaming computation din ng natural increase. So, CRVS data applies common standards and definitions as defined by UN, and the use of standard definitions permits comparable, not only over time, but also across countries. CRVS data is complete because by law, civil registration covers the whole population. Thus, we can identify inequities between different areas and population groups. CRVS data is correct because vital events are recorded as close as possible in time and place where they happen. And it collects information on the occurrence of each death and its cause and key characteristics. So yan yung advantages ng paggamit ng ating CRVS data compared sa other surveys na kinakandak ng every like yung NDHS, this is conducted every 3 years or 5 years, I think. 5 years. And yung ibang mga health, yung family planning survey dati is every 3 years. So, yun yung kaibahan ng CRVS data compared sa other surveys na ginagamit din as indicator para sa health. In the next few slides, we identified 3 uses of CRVS data specifically for monitoring on the following. So, andyan yung Sustainable Development Goals, Philippine Development Plans, and CRVS Decade Goals and Targets. I will also present the stakeholders who are using CRVS data. Next. So the role of CRVS system was acknowledged by the global development community in the Sustainable Development Goals with its central principle that no one will be left behind. CRVS data play an important role because 15 of the SDG goals and 24 of the SDG targets require CRVS data for measuring the indicators, in particular numerators, the births and deaths, and denominators, the total population, live births, total deaths. 14 SDG indicators specify cause-specific mortality. And SDG requires timely and continuing data series to enable comparisons over time. So, yun nga, as mentioned, ang ating vital statistics na kinukuha from civil registration ay yearly, meron tayong data. Kasi continuous siya, ang registration. SDG call for data at national and subnational administrative levels. So yung ating CRVS data, up to municipality level ang pwede nating ma-generate. Compared sa mga surveys na minsan, up to regional estimates lang, sometimes at the provincial level. In this slide, I include only those targets that CRVS is addressing the SDG goals. So meron tayong 3 SDG goals where CRVS data is addressed. So ito yung goal 3, ensure healthy lives and promote well-being for all at all ages with 3 targets. So meron tayong target 3.4. Ito yung by 2030, reduce by 1/3 premature mortality from non-communicable diseases through prevention and treatment and promote mental health and well-being. So, ang sinasabi natin dito ng non-communicable diseases, ito yung mga lifestyle diseases like yung mga ischemic heart disease, yung karaniwan na sakit ngayon, yung mga may diabetes, may daya, sabi. Sa pagkain, dinadaya. And also, target 3.6, by 2020, half the number of global deaths and injuries from road traffic accidents. And then target 3.9 by 2030, substantially reduce the number of deaths and illnesses from hazardous chemicals and air, water, and soil pollution and contamination. So yan yung mga targets na nasa Goal 3. For Goal 16, next slide. Promote peaceful and inclusive societies for sustainable development, provide access to justice for all, and build effective, accountable, and inclusive institutions at all levels. At meron siyang one target. Ito yung target 16.9. By 2030, provide legal identity for all, including birth registration. So dito pumapasok yung CRVS. And Goal 17, strengthen the means of implementation and revitalize the global partnership for sustainable development. At meron tayong isang target dito. Ito yung sa target 17.19. By 2030, build on existing initiatives to develop measurements of progress on sustainable development that complement gross domestic product in support statistical capacity building in developing countries. So under this target, meron tayong 17.19.2.2. Ito yung proportion of countries that have achieved 100% birth registration and 80% death registration. So, ang ating target lang sa Philippines, dapat makuha natin yung 99.5% by 2024, ang birth registration. So, for the 2021 Vital Statistics Report, we plan to include section on the SDG indicators. So, pwede nyo pong, yung 2021 namin ay ma-release siya by next year. So the indicators in the Philippine Development Plan also encompasses that of the SDGA, which include proportion of children under 5 years of age whose births have been registered with the civil authority. That is, it should increase. Maternal mortality ratio decreased. Mortality rate attributed to cardiovascular disease, cancer, diabetes, and chronic respiratory diseases will decrease. So ito yung mga number of deaths per 100,000 population aged 30 to 70 years old. So kasi ito yung ina-expect natin na magkakasakit nitong mga NCDs. And then death rate due to road traffic injuries decreased, mortality rate due to unintentional poisoning. So however, there are 4 in the additional PDP indicators where survey was the source. But if we assess it, CRVS data can be used to generate these indicators. So ito yung neonatal mortality, infant mortality, under 5 mortality, and yung adolescent birth rate. So itong mga indicators na to, ang source of data nito is from surveys pa. So pwede naman nating makuha siya sa CRVS kasi ma-generate naman siya. So for the CRVS decade target indicators, next. Vital statistics is addressing Goal 3, accurate, complete, and timely vital statistics, including on causes of death, are produced based on registration records and are disseminated with 8 identified targets. So ito yata yung sa CRVS decade na merong 8 targets. So target 3A, by 2024, annual nationally representative statistics on births disaggregated by each mother, sex of child, geographic area, and administrative subdivision are produced from registration records or other valid administrative data sources. So actually, meron na tayong generate nito. So matagal na sa lahat ng ating vital statistics reports. Target 3B by 2024, annual nationally representative statistics on deaths disaggregated by age, sex, cause of death defined by ICD. Ito yung International Classification of Diseases. So ang ating ginagamit na version is ICD-10. So by next year, we will be implementing the ICD-11. So ongoing yung training, di ba si Miss Cha? Ang DOH ang kwan dito, nag-organize. So, geographic area and administrative subdivision are produced from registration records or other valid administrative data sources. Yung target 3C naman, ito by 2024, at least 100% of deaths occurring in health facilities or with the attention of a medical practitioner have an underlying cause of death co-derived from the medical certificate according to the standards defined by ICD. And then, meron tayong target 3D, by 2024, the proportion of deaths coded to L-defined codes will have been reduced by 50% compared with the baseline year. Sa target 3E, by 2024, at least 85% of deaths taking place outside of a health facility and without the attention of a medical practitioner have their underlying cause of death code determined through verbal autopsy in line with the international standards. Target 3F, by 2018, key summary tabulations of vital statistics on births and deaths using registration records as the primary source are made available in the public domain in electronic format annually and within 1 calendar year. Within 1 calendar year ba kami? Malalaman natin mamaya. Target 3G, by 2017, key summary tabulations of vital statistics on causes of death using registration records as the primary source are made available in the public domain in electronic format annually and within 2 calendar years. 2 years pa ba? Yan ang tanong eh. Target 3H, by 2019, an accurate, complete, and timely vital statistics report for the previous 2 years using registration records as the primary source is made available in the public domain. So ang ating national target value is 100% completed. So later in session 6, this afternoon, we will see how near or far are we from the targets. So i-assess natin kung itong mga targets na to sa Goal 3 ng CRVSDK ay nasa kwan ba tayo? Okay na ba tayo or hindi pa rin? So let me now give you our stakeholders who are using CRVS data. We have international and local. For the international stakeholders, we have among others the UN agencies. These are the UNSD or the United Nations Statistics Division, wherein yearly we update the UN Demographic Yearbook Annual Questionnaire on Vital Statistics as well as on population and housing. UNIGMI, ito yung Agency Group on Child Mortality. We are providing data for the child mortality estimates. Yung World Health Organization naman, most of the time we provide data on births and deaths by cause. Yung Institute for Health Metrics Evaluation, we provide data on deaths by cause for use in the global burden of disease. So yearly din nagbibigay din tayo doon. For our local stakeholders, we have the following. Ang ating main stakeholder dito, syempre, yung Department of Health. We provide data on deaths by cause for their annual report of the Field Health Information System and for other DOH programs such as yung TB, yung tuberculosis, HIV, cancer, maternal and child health. Yung Commission ng Population naman, madalas is we provide birth statistics. And then yung NEDA, during the pandemic, we provide data on number of deaths and COVID-19 deaths on a weekly basis. So weekly kami nagge-generate ng data ng number of deaths and COVID-19 deaths for use by the Interagency Task Force for the Management of Emerging Infectious Diseases. So yung other government agencies dito, yung DOST, yung ADB, House of Representatives, madalas yan sa kanilang planning, paggawa ng mga plans. Yung sa academe naman, yung UPPI, Ateneo, and others, researchers, and then meron din kaming media, hindi ko dyan nailagay. Yung kadalasan dito, yung ABS-CBN, Reuters, Rappler, and others. Yung other government agencies dito, ayun na-mention ko na. And then yung researchers, for their thesis, karaniwan, ginagamit nila sa kanilang mga thesis. So for next slide. So ito naman yung slide na to, ito yung mga laws that were passed where CRVS data was used as one of the bases in preparation of the law. Ito yung RA 8750 on the use of seatbelt devices. So ang provide natin na data dito is on deaths due to land transport accidents. Yung RA 10351 on the sin tax reform law, data on tobacco-related deaths such as lung cancer, coronary heart disease, tuberculosis, so etc. Yung RA 10354 naman, ito yung Responsible Parenthood and Reproductive Health Act. So ang we provided data on maternal and child health naman. And for RA 10223 or the Universal Healthcare Act, so ang data na hinig dito ay yung sa ginamit din sa global burden disease. Ito yung mga causes of death din. Then RA 11229 or an act providing for the special protection of child passengers in motor vehicles and appropriating funds thereof, or the Child Safety and Motor Vehicle Act. Ito yung ang provide namin data dito yung transport accidents of children. And then yung RA 11596 or the act of prohibiting the practice of child marriage and imposing penalties for violations. So ito yung naisama namin dito na RA, yung ito naman for marriage. So yan. So ito yung other sources of CRVS data. So siguro hindi ko na masyado i-discuss ito. Anyway, nasa website naman, ilalagay namin siya sa website. So na-mention ko naman dyan yung tracking natin sa SDGs, sa other, for planning, monitoring, evaluation of effectiveness, health interventions, ano bang pwede dito? Ayun. So, na-mention ko na rin naman siya. So, hindi ko na siya i-discuss. Okay, next slide. So, this slide shows the CRVS data dissemination materials. We have press releases on deaths by cause, special releases, vital statistics reports in 3 volumes for birth, marriage, and death, infographics for our preliminary results, public use files, containing the raw data without the names, and conducting dissemination fora usually during the celebration of the Civil Registration Month in February of every year. So I am pleased to inform the group that nung starting early 2016 pa, we released data which in fact less than 1.5 years after the year of occurrence. So hindi siya 2 years. Then in 2017, we started releasing preliminary vital statistics 6 months after the reference year. So siguro hindi kasi sila masyado nagtitingin sa PSA website, nandun lahat siya. For the 2018 data, we initiated providing provisional data in a quarterly basis, releasing key statistics 3 months after the reference quarter. And the last quarter of 2021, we have been releasing monthly key statistics on births, marriages, and deaths within 2 months after the reference month. So ang yung recent na nirelease namin is as of August 31, 2022 na data. So you can visit our website sa Vital Statistics. So during the onset of the pandemic in 2020, we started providing cause of death statistics and updates through press releases, and along with the key vital statistics have been released on a monthly basis starting last year. For the dissemination fora, we had already conducted twice. First was in 2020 before the start of the pandemic. Ito yung March 3 yata ginawa. And then after a week, nag-lockdown na. And then the second was conducted this year during the culminating activity of Civil Registration Month. Nitong February lang. So let's have some updates on birth and death statistics. Next. Okay, next. So in 2021, a total of 1,364,739 births. Next slide, please. registered from January to December, lower by 10.7% than the total registered births of 1,528,684 in the same period in 2020. The decline in birth registration might be affected by the pandemic in the registration of births due to the quarantine measures imposed. Kaya medyo yung registration natin noong 2021 ay medyo mababa. So, ang sex ratio is 109 births, male births per 100 females. Next. About 2 in every 5 births were born to mothers residing in Calabarzon, NCR, and Central Luzon in 2021. So, yan yung mga maraming ipinapanganak sa NCR, Central Luzon, and Calabarzon. Next, these are the top 5 provinces in terms of number of births, and Cebu is ranked 3rd noong 2021. Next. Sa top 5 cities naman, ang Cebu City naman ay nasa 5th among the cities with high number of births. So ang number 1 dyan is Quezon City, followed by Davao City, Manila, Caloocan, then 5th is Cebu. In 2021, a total of 879,429 deaths, next slide please, registered in the country from January to December 2021, higher by 43.2% than the total registered deaths of 613,936 in the same period in 2020. So biglang laki, almost half, almost more than half ang dinagdag na-increase ng death nung 2021. Ito yung time ng COVID. So talagang madami siya. A sex ratio of 126 males per 100 females. So mas maraming namamatay na lalaki nung during the time of pandemic. And then September had the most number of deaths registered in the country with 119,758 or 13.6% of the total deaths in 2021. So siya yung pinakamadami. Ito yung time ng yung Delta variant of COVID-19 was ito yung dominant variant. Ito yung marami talaga yung namamatay. So yan. So ang lowest niya is noong February. So hindi pa siya masyado. Okay, next. And then ito naman yung top regions, provinces, and cities in terms of registered deaths. So sa top 5 provinces, ito yung Cavite. Number 5 yung Cebu. Sa top 5 cities naman, yung city of Cebu naman is number 5 pa rin. So Quezon City is number 1. Followed by Manila, Davao City. Kung titingnan niyo po yung top 5 cities, almost the same siya sa births. Yung rank niya. Okay, next. Ito naman yung top 3 causes of death in the country in 2021. Ito yung ischemic heart disease, cerebrovascular diseases, and COVID-19 virus identified. So number 3 yung COVID noong 2021. Ito yung virus identified. In the same period of 2020, the leading causes of death were ischemic heart disease, neoplasm, ito yung cancer, and cerebrovascular diseases. So, pag sinabi natin COVID-19, refer to both confirmed and probable cases in 2021. Ito yung COVID-19 virus identified. Yung yung ating yung COVID-19 ay unidentified number 1, 2, 3, 4, 5, 6. Number 8 naman siya. Ito yung hindi pa possible na before namatay yung person, na test siya, so hindi pa siya lumabas yung result. So later na siya nalaman na positive. So tinitreat natin siya as unidentified pa, pero COVID siya. So kung mapapansin niyo po, di ba meron siyang meron tayong inconsistencies with the DOH na nire-release yung COVID-19. So mas madami actually ang nire-release ng PSA kasi magkasama na yung COVID na identified tsaka yung hindi unidentified. So ang pagkakaiba kasi namin with DOH, siguro makakapagsabi dito ang mga taga-DOH, yung ang nire-release lang ng DOH yung mga yung identified na talaga. So kasi nagkakaroon sila ng validation. So yung PSA, wala kaming validation kasi whatever that certificates na dumarating sa amin, yun yung aming kinocode. So it's either unidentified or identified. So yun yung pagkakaiba po ng data namin ng DOH na nire-release. Okay? So in 2021, yung top 3 regions with the highest number of deaths due to COVID-19 occurred in Calabarzon, National Capital Region, and Central Luzon. So mga nasa 60,917 itong tatlong regions na to. So, makikita nyo naman na pinakamarami. Yung yung ARM ay medyo, siya yung pinaka-lowest, 162. Okay? So now we'll go to the challenges and issues we face in collecting and processing the data. Andyan pa rin syempre yung timeliness in the submission of monthly reports, transmitted documents from the local civil registry offices and PSA field offices. And then yung timeliness in the processing and generation of vital statistics. Siguro, i-mention ko na rin na pinoprocess kasi namin yung data. Actually, yung process namin, once na ma-encode sa provincial offices, yung mga death certificates, isasubmit yan sa central office. So, nauuna yung data files na ma-submit, and then hihintayin namin yung physical document, yung death certificate mismo, kasi kailangan namin i-check kung na-encode ba lahat, lalo na sa causes of death. So, yun yung tinitingnan talaga namin 100%, yung verification kung nailalagay talaga sa lahat, nai-encode lahat yung mga description sa causes of death. And then andyan yung completeness and consistency of entries reported encoded by the LCROs, PSA field offices, especially on the description of all causes of death. And then yung common errors in the entries in the medical certificates portion of the death certificates. So ang napapansin namin dito na madalas na makita namin during the processing ng death certificates, yung multiple causes per line. So, yun yung aming problem kasi dapat, per line, dapat isang cause of death lang. Illegible handwriting of doctors. Pasensya na po yung mga doctors na nandito. Minsan hindi talaga mabasa yung inyong sulat kamay. Then, poorly specified condition. Hindi na i-specify yung talagang tamang condition ng cause of death. Insufficient information on the external cause of death. So, yun din yung kulang. Insufficient information on neoplasm or yung cancer. So, dapat specific kung anong site. Kasi lahat ng causes of death, may corresponding code yan. Sa cancer, kailangan tingnan kung site, saan banda, and then dapat specific talaga yung pagkakasulat. Then, presence of blank spaces within the sequence of events. Minsan may mga blanco. So, kung titingnan nyo po yung death certificate natin, may 3 lines dyan. Okay. Ay, malapit na. Anyway, malapit na. Then, absence of disease time interval. Ito yung kulang din. Fails to identify pregnancy and maternal deaths. Low coverage rates among Muslims and indigenous peoples. Quality of causes of death data, which greatly affects the reliability of mortality statistics. And then fast turnover of trained ICD-10 coders, lack of basic knowledge on medical terminologies and coders. So now, ito yung challenges and issues. So, okay, next. So ito yung ways forward natin na hopefully ma-address sa mga challenges. Ito yung digitalization ng PhilCris, CRVS system through enhanced PhilCris na kung magagamit ng mga LCRs, tsaka ng mga institutions, ito yung mga hospitals, kung magagamit nila, so maiiwasan natin yung sulat kamay na hindi nababasa ng maayos. Then continue birth and death registration projects for the low level of registration in the country. Use of IRIS version 5 for coding of emerging diseases such as COVID-19. And the implementation of IRIS 11 using ICD-11. And then implementation yung VEI system sa lahat ng provinces. And continuous training on ICD-10, MCCOD, IRIS for the quality of death data. Okay, next. So before I end up my presentation, let me quote from Social Care Business. Every time data is collected, collated, processed, analyzed, and presented or shared, it must be for the benefit of the people we support and not just for the sake of having lots of data and information. Okay, thank you.
Thank you, Ma'am Au. Yeah, ang ganda nung ending, parang just to emphasize we're not just collecting data for data's sake, but it's really about data use. So we're excited to hear from various, at least the two major sectors that are supposed to be using all of these CRVS data. Sir? Pardon that. Our first speaker is from NEDA, the Regional Office 7, and is the Assistant Regional Director. Our speaker began preparing for a career in basic education, but went on to acquire a master's in business management, and then did most recently, the latest studies that she took was a diploma on governance and democratization and public policy at the Institute of Social Studies at The Hague. And our speaker has worked at the Department of Agriculture before becoming part of the NEDA Regional Office 7. Please welcome Ms. Maria Asosteline Padilla, the OIC Assistant Regional Director for NEDA Region 7.
Good morning. So I'm tasked to discuss or say comment on the presentation of Ms. Aurora Talan Reolalas. Thank you, ma'am, for that presentation. And then my discussion will cover two aspects. The main first one is on the utility of the CRVS. Let me remove my mask first. And the second one is what are the recommendations that particularly on some of the challenges and issues presented by Ms. Aurora. We have seen how the CRVS data can be a tool in evidence-based monitoring of the Philippine Development Plan and our commitments under the Sustainable Development Goals. And I would like to inform everyone that the targeted outcomes covered in the Philippine Development Plan and in the Sustainable Development Goals hopefully will lead us all to the ambition, the long-term vision of the country, which is ambition natin 2040 for a matatag, maginhawa at panatag na buhay for every Filipino. The NEDA Regional Office 7 is now in the process of formulating the Regional Development Plan for 2023 to 2028. Part of the planning process is the assessment of regional targets, and part of which is related to the Sustainable Development Goals. The other half of the planning process is the formulation of challenges, targets, and strategies. And this should be backed by statistical data, and to the extent possible, targets would be backed by vital statistics. Demographic studies using CRVS data form the foundation of other sectoral studies in comprehensive plans, such as those for the social sector, economic sector, and infrastructure. Note that the CRVS is not only useful for social planning, but also for economic, infrastructure, and even development administration planning. Using the latest CRVS data and the established service standards, the planners are able to estimate how many houses to construct, how many hospital beds to provide, how many classrooms to build, how many public health workers to hire, how many police and fire protection personnel to deploy, how much land to allocate for economic activities, how much water supply to secure, how many kilometers of roads to build, and the long comprehensive list goes on the use of birth and death statistics. But we would like to emphasize that it's very clear to us that the CRVS is useful at the regional level. We would like to emphasize that it is more useful also at the local level, particularly in local planning, in the formulation of the comprehensive land use plan, and in the comprehensive development plan. And I would like to highlight that as the local government units as one of the major stakeholders of CRVS. Because I noted in the presentation of Ma'am Aurora, there were other government agencies, but I would like to emphasize that this is also very useful at the local level. As you know, registration starts at the local level. Utility of the data from the registration at the local level should also be trickled down at the local level. Right now, we're trying to make efforts towards studying how far statistics is being used in local planning, particularly in the identification of local programs, projects, and activities. Especially this importance in local planning and evidence-based planning using, among others, CRVS is emphasized given the Mandanas ruling, wherein more resources are now poured to the local government units. So the land use plan, which is a local plan, has at least a 9-year time horizon. Thus, aside from determining the present needs, CRVS data is also used to project the future needs of cities and municipalities. So if I think population data is every 10 years, but if we have this annualized CRVS trickled down to the lowest level of government, then this can be used for the future projections of cities and municipalities. These present and future needs will be the basis for identifying, programming, and budgeting investments. CRVS data also becomes an important reference in monitoring and evaluating projects. Now, in terms of the challenges and issues that was presented by Ms. Aurora, at the regional level, the NEDA sits as the chair of the Regional Statistics Committee, and this is the Philippine Statistics Authority Regional Office sits as the secretariat of this committee. This committee at the regional level sets the policies and advocates policies related to the strengthening of our statistical management system. I noted that in the program, there is number 2 objective is of this activity is to identify key action areas to actualize the CRVS National Plan of Action. We may take into consideration the existing structure of the RSC as a mechanism to promote and not only to plan, to contribute to this National Action Plan, but also to promote this action plan. In terms of the timeliness, the major timelines that may be considered is, of course, the timeline for the medium-term plan, which is every 6 years, and there's a midterm update of this plan every 3 years. On an annual basis, the NEDA produces the Regional Development Report, from which we present the status of the different indicators, development indicators, including the status of Sustainable Development Goals accomplishment in the region. By the way, the NEDA in the region also is the Secretariat of the Regional Development Council. Under the structure for the monitoring of the Sustainable Development Goals, the Regional Development Council is tasked to coordinate the monitoring of the accomplishment of these goals. So annually, we produce these reports also. And I think lastly, we would like to see a stronger or wider promotion of the CRVS, not only of its availability, but how it can be used not only at the regional level, but more so at the local level. So with that, I would like to end my comments as discussant of this topic, translating data into evidence for decision making. Thank you again for this opportunity.
Thank you, Assistant Director Padilla. And really very exciting for really presenting how CRVS should be actually used. I was wondering really as a doctor, aside from birth and death statistics, so do you really use it for planning the number of hospitals and health professionals? Yan. So now that we're going to listen to two representatives from the health sector. So our first speaker is Dr. Gloria Nenita Velasco, Director 3 of the National Epidemiology Bureau. She has an eclectic professional experience and training characterized by an intertwined interest in both research and policy, spanning from her earlier education in liberal arts and medicine to her later training in clinical epidemiology at the UP, and more recently, her postgraduate training in health systems management and policy at the Institute of Tropical Medicine in Antwerp. Her interest in bridging the gap between evidence generation and public health practice has only intensified through the years of being part of the flagship fellowship program on health policy and systems research, and as part of the Health Research Division of the Health Policy Development and Planning Bureau. Currently, she is the Director 3 of the Office of the Health Statistics and Systems Development. She brings training and experience in evidence generation, policy making, and systems development and management to ongoing efforts at restructuring the Epidemiology Bureau towards the end of universal health care. Please welcome Dr. Gloria Nenita Velasco, Director 3 of the DOH Epidemiology Bureau.
Good morning, everyone. I will try my best not to also respond to some of the things that were also mentioned by the previous discussant. Just very shortly, though, I would like to just say that, the difference between the COVID statistics that are actually released by PSA and the COVID data released by the DOH, I think the simplest answer to that is really a difference in methods. I think we understand, no? How you collect data really matters. So that's the short answer to that. But I think more than that, what is important is that, when we release information, these are both national agencies. So from a communication perspective, not that we are, not that it is even always possible to come up with one source of truth, but it's very important that from a perspective that people, the general public, appreciate that the agencies speak with one voice. So, explaining these differences and trying to come to as close to figures as possible, that is important. And I guess for the information of everyone, there are ongoing efforts actually to better reconcile the data that is released by PSA and by the DOH. So for us agencies, especially for agencies that are expected to act on things, that is very important. We want to build trust with the public. And that also means being more transparent with the information that we have, but also more actively collaborating with other agencies that also play an active role in producing information. Also, that's very important for the public to see. I'm also happy that Ma'am from NED actually mentioned, there's always a lot of expectation, and rightly so, no, of national agencies to be using data and information in their decision making. But all the more now, no, and we also experience this, how important it is at the local levels for our decision makers there to be actively using information in their decision making. And I say that not just because of the LGC, but that is where we collectively feel the impact of what government is doing. So if our LCEs commit to that level of information use, no, I think that's even more democratic. Information is power. And so we also understand the challenges of that. The way that we've historically been using information in the public sector, it's always linked to performance. And and we understand, no, there are actually conflicts of interest in that for people who make decisions, no? So when if the general public know that these are the issues of our communities and their decision makers don't act on that, that makes the people more powerful. They can make those kinds of the decisions in elections. Like, I will no longer vote for this individual. So we see this push and pull and these tensions that are actually existing at the local level. But nonetheless, no, we share that same sentiment. Now, for universal healthcare to really be felt, obviously the national agencies play a very big role, but all the more so at the local level. That is where services will be felt. And as it is right now, because of our devolved setup, our local decision makers are very powerful and they can be more impactful that way. And then I also like that she highlighted just the general use of data. No, we keep on saying that you should use data, you should use data. But even from my own personal experience, having been presented data and also doing the same for other decision makers within the DOH, no, how you communicate, that really matters. So right now, I think our collective challenge for any institution that produces data and wants to communicate this information, we really have to stretch ourselves now. It's not enough to disseminate information. That is also our own personal challenge in our bureau. So, of course, the report as we know it, no, that will never go away. We really need to have those, but really those are not enough. So that is a shared challenge, no? Hindi lang po sa PSA, pati sa DOH, and more importantly po sa bureau namin. That's a shared challenge. So going back to the presentation ni Ma'am Aurora, thank you very much po for that. I just really wanted to highlight a collective challenge for every one of us. No? There was an extensive list, actually, of potential uses of CRVS. No? I guess I just want to twist it a bit. For us, as people who produce information, we need to have use cases, actual use cases. And that would be really helpful, not just for national agencies, but any institution that has to use information. No? It might be ironic to say this, but we need to be able to say very explicitly how you should be using this information. So I guess in partial response to Ma'am Portia, no, birth data and death data. No? Death data very clearly, for us, main source of information for prioritizing which conditions actually need to be addressed. So we already see a lot of deaths from NCTs, and that is quite clear, no, na the past 2 or 3 decades, nag-shift na po siya, no. The burden is, I wouldn't say equally shared, but it is shared with communicable diseases. No? So prioritization, definitely, pumapasok yun. For birth data, we're actually happy, no? Now that PSA has reported that they're actually able to capture 95% of births in the Philippines. So for us in the department, we've been using births actually to help us budget for commodities, no? So that's a very explicit, actual use case that has been happening for decades na rin. And we've been using projections for that, but you know what? If it is true, no, that we're able to capture 95% of births, then I see no reason Now, why? We shouldn't be using this data to actually plan and budget for commodities for which we need that kind of information. No? So mga ganon. Those are actual use cases. So I also noted na a lot of the uses are in government, hindi lang po sa DOH, no, even the other sectors, but really for monitoring and reporting. So I've shared also this challenge sa staff ko, and even with other offices that use information produced by our bureau. It has to go beyond monitoring and reporting, no? Reports are tangible end products, and they are still of value, but if you recall what I said yesterday, no, the challenge for the department is to be more impactful. So you tell me how impactful a report on its own is. No? And I think, safe to say, no, it isn't on its own. It needs to be used. It needs to influence decisions. So that's the kind of use cases that we need to better highlight, and which we're also committed, no, to doing for the department. So yan yung challenge din po sa amin bureau, sa bureau po namin. The second point I'd like to share is that, yes, CRVS data is useful for decision making, but I would also like to challenge everyone, and the fact is, no, for our decision makers and policy makers, we just need other information as well. Diba? Kasi you can tell us what the burden is, and that is important for us to know, but you know, the next question of someone who needs to decide, someone who needs to perhaps develop a policy is, what do we do? Diba? So you can't just tell me what the problem is. The next question, I'm almost 100% certain, they will ask you, so what do you suggest we do? You know, so if we are unable to give that kind of information of our decision makers, that also cuts their decision-making process. No? We want them to be more effective. So yun, diba? We use statistics that we get from CRVS, but that should be coupled with other information. What should I do? Is that, in your opinion, the most effective? Is that even feasible in our country? No? How much will that cost? How can we implement? Those are the next questions, diba? So if we're unable to answer those, no, we're not as effective as communicators of information. And that is a collective challenge for everyone. Not just for the PSA, not just for our bureau specifically, but anyone who produces and communicates information to people who need to develop policies, people who need to make decisions, whether at the national or at the local levels. And then, you know, my heart is still with research and policy, and you know, with my own practical experience, having had to communicate myself, having observed people communicate to decision makers, timing really, really matters. I really cannot underscore that. It's not just an issue of being able to secure time of people who make those decisions, or you know, if we're talking about schedule, but it's other things too. You know, so just one of them is, you need to think, no? For instance, if you are presenting information, you're saying that you need to prioritize this, you need to invest resources on this problem, no? A very important consideration is, for any institution, where are they at in their budget and planning cycle? That really matters, especially if you're making the point that you need to act on this now. That really matters. If you present this at the wrong time, what that means is, no, for the institution, let's say, in principle, they agree with you, but what you are recommending, but that also means there is already a delay in implementation, more likely, because they do not have the budget for that, no? More, ganun po yun, no? Or but you know, the reality is they will also try to look for resources. But even that, so that's what matters, no? Where are they at in the budget and planning cycle? And you may be familiar with the policy window, but my mindset always, when I speak to someone who needs to make a decision, no? It's always thinking of, where are we at? Is the problem big enough? Do we actually have a solution for it? Is there political support for this? I always think of that. Even within institutions, there are political dynamics too. You know, so even when I speak to our bosses, this is always my mindset. There's always a window of opportunity. Is it the right time to be speaking on this particular issue? So, because it is a window of opportunity, no, this window actually opens and closes, no? For people, I think the major frustration is when the window is closed, especially when you feel very strongly about a certain advocacy. Very frustrating to be said, we can't do that right now. But I will also say, the window is never closed. It's not permanently closed. It does open, no? So I think if ever that would be my last advice for anyone actually wanting to communicate information, always remember that. Windows are not always open, but nor will they remain closed. So you just need to be smart on when and how you communicate to people, no? And I think also from personal experience, really persevering. When we work within the context of a health system, this is always a marathon. It's never a sprint, no? And I think we know that, especially for mga kasama po natin ngayon na matagal na po sa public service, no? It really is a marathon. And with that, thank you very much. I look forward na rin po sa mga ibang tanong ninyo. Thank you po.
Dr. May, you were my student. Oh my gosh. So our young ones are now taking the helm. So I'm happy to finally realize that she was also among my students. And I'm happy to see more are actually going into public health. When before, doctors are just in the clinic, so expanding precisely because of the need. So I want to remind you, please pipe in your questions so that we can have an exciting discussion. And really the comment of Dr. May here earlier on is really how to communicate and communicate effectively so that definitely the data will actually be used. So we'll listen to another expert in public health, Dr. Ronald Quintana. Currently works as a medical officer of the Partnership and Data Management Division of the Disease Prevention and Control Bureau. Prior to this assignment, he was lead of various task groups in terms of disease prevention, including negotiation and diplomatic engagement for COVID-19 vaccines, finance and procurement of the COVID-19 vaccines, and worked also at the regional coordination team. He was alternate assistant manager of the DOH Emergency Operations Center for COVID-19. He also worked on the National Malaria Control and Elimination Program, the National Rabies Prevention and Control Program, and the Emerging and Re-emerging Infectious Diseases. Prior to this, he also worked with the WHO, local government units, and other international and local non-government organizations. Please welcome Dr. Ronaldo Quintana of the DOH Department of Disease Prevention and Control Bureau.
A pleasant good morning to everyone. On behalf of the Disease Prevention and Control Bureau, I would like to thank you for the invitation to this conference. The Disease Prevention and Control Bureau, as the name implies, is the bureau in the Department of Health that is responsible for the development of policies, guidelines, and plans that aim to prevent, control, and eliminate various diseases, both communicable and non-communicable. In the development of these policies, guidelines, and plans, the availability of accurate, good quality, and real-time or near real-time data, including vital statistics, is of utmost importance. The Bureau ensures that these important documents shall be evidence-based so that they will be able to address head-to-head in a more cost-efficient manner, as well as more appropriately responsive to the problems and challenges posed by various diseases, including those that relate to maternal and child health. Just recently, the Bureau developed an important document called the Omnibus Health Guidelines, which was issued through the DOH Administrative Order and disseminated through the DOH Department Circular. The Omnibus Health Guidelines was developed using the available data as reference. The Omnibus Health Guidelines integrate the standards of care for service delivery from health promotion, prevention, screening, diagnosis, treatment, rehabilitation to palliation, for various life stages and settings. The standards of care have been derived from the recommendations of quality-appraised local and international clinical practice guidelines, research studies, other evidence-based references, relevant laws, and evidence-based policies, which all utilize data as one of the bases in the development. The initiative is aligned and consistent with the universal healthcare principles and contributory to the aims of the Universal Healthcare Act, related to health reforms on providing an integrated and comprehensive set of quality and cost-effective services covering the spectrum of care and transforming the health system focus into a primary care-oriented and people-centered care. Likewise, recent landmark national laws such as the National Integrated Cancer Control Act and Mental Health Act, where DPCB played an important role in crafting the bill and advocating for its passage, also utilize available data on cancer and mental health and other relevant data as reference during its development. These laws paved the way for the establishment of the Cancer Control Division and the Mental Health Division in the Department of Health. Currently, the Infectious Disease and Adult Health Division of the Disease Prevention and Control Bureau has started to develop the Multi-Disease Elimination Plan. Available relevant data serves as one of the bases for the prioritization of diseases that will be initially included in the plan, including the decision on what strategies that will be undertaken for disease elimination. All these policies, guidelines, and plans are proofs of how data are translated to evidence for decision-making. This underscores the importance of having accurate, complete, timely, and good quality data, which has been mentioned a number of times in yesterday's sessions. With digitalization, the issues and the timely submission of monthly reports of transmitted documents, as well as the timely processing and generation of vital statistics, will hopefully be the solution to address these challenges. However, they should have parallel actions targeting to improve wireless fidelity and internet connection. Continuous training with subsequent training evaluation and supportive supervision of encoders will hopefully address the encoder-related issues and challenges. Capacity building activities on ICD and medical certification of cause of death will hopefully address the issues on the quality of causes of death data and other health service provider-related challenges. Relative to the sessions yesterday, the action areas that were mentioned and discussed are important elements that must be considered to make improvements and achieve a well-functioning CRVS system that shall serve as good source of public health data which could be used for the development of evidence-based policies, guidelines, and plans at all levels of the health system. Moreover, no one can disagree that a complete CRVS system is one of the best sources of data for measuring indicators, both for local and international plans and goals. Having reliable and up-to-date vital events information supports making informed program and policy decisions, ensuring the accurate use of funds and monitoring of development programs at all levels. Lastly, I think and I believe that equally important as policies, guidelines, and plans, if not more important, is the translation of these policies, guidelines, and plans into concrete actions at the national, subnational, and local levels, utilizing the whole of society, whole of government approach that espouses multi-sectoral and multi-agency collaboration. Related to this, there is indeed a need to increase data literacy and to transform data into layman's perspectives that could be easily understood by the decision makers, policymakers, planners, and advocacy groups at all levels, so that appropriate and relevant policies, guidelines, and plans could be developed which could be easily translatable to realistic and doable actions that are people-centered, family-focused, and community-oriented, which will benefit the majority, especially the underprivileged, marginalized, disadvantaged, and vulnerable segment of the society. That's the end of my discussion. Thank you very much.
Thank you, Dr. Quintana. You ended with a line being used in the department. So patient-centered, family-focused, and community-oriented. So I'd like to ask Maricel to present the questions online, and I'll ask Ma'am Au to come around. Maybe you have thoughts already to the points raised by ARD Padilla, Dr. Velasco, and Dr. Quintana. May initial comments po ba? Sige. Mamaya po, hihingin ko yung mga tama-tama ni race ni Ma'am Au, ni Chief Au, about the other stakeholders. If you actually, what are your use of the current CRVS data? Please share your stories, because this is, to document this is as important, diba? And really parang putting value to all the efforts that we are doing in collecting the data. So the next step should be data use. Meron po bang comments? Okay, sige. First question. For the academic community, how can faculty members and students access CRVS data for research purposes? Yan. Siguro, Ma'am Au, dito ka muna. May I ask the banquet to help?
Yung question for the academic. They can only email us, our office, to request for the data. So yun yung mga kapag kung wala sa aming website, kung kailangang i-generate, so we also provide also the public use files for use by mga researchers kung ano yung mga kailangan nila. As long as nandun sa aming data sets.
So there's interest in the academe and the researchers really to access and use the data. We'll post later on the email of PSA so that you can request specifically if all the data that you're thinking of is not actually available on the website. Maybe we can also ask our colleagues from the Department of Health as well as NEDA kung meron po bang datos na available sa inyo that the public can actually use also for their own purposes as well as for governance and so on. Yan.
As far as for the NEDA regional office is concerned, most of our data that we use for our planning activities and even for policy formulation is access to the PSA website. But right now we have high frequency data. That means there are data that is required not only on an annual basis but within a particular year. And together with the PSA as Secretariat of the Regional Statistics Committee has established this Regional Statistics Data Bank for high frequency naman, hindi yung mga annual data. That is an opportunity for the agencies, not only PSA, to encode certain statistics that may be available in the, for the public. Right now, it can be accessed through the website of NEDA Regional Office 7. So these are, NEDA is not a statistics a user, but for purposes of facilitating consolidation of high-frequency data, we have established this data bank.
And I understand po, diba, that NEDA is the bigger agency under which the Philippine Statistics Authority is under.
Actually, as I mentioned, at the regional level, NEDA sits as the chair of the Regional Statistics Committee, which sets the policy directions in terms of statistical management in the region. Kaya nga, nirecommend namin na you can use the RSC as a mechanism to promote the National Action Plan for the CRVS.
Thank you, Dr. Padilla. Yes, Dr.
Yes, for us at the DOH, no, so our bureau actually produces data information. A significant portion of that is already available online, publicly available. No? So our website is already live. We have also the COVID data that's already been, the data sets have been publicly available ever since, so that continues to be available. Directionally, we want to make more data available to everyone. We facilitate data requests, so you must be familiar with FOI. So of course, well, we do our best effort not to release this in a more timely manner. But we want to eventually do away with those type of requests by making data publicly available already. So you won't have to make that kind of request. That will also mean directionally for us, no, policy-wise, also developing data access policies that promote this, no, and actually that will make this part and parcel. There are already indications in the UHC Act already that basically say that, you know, data, if it is funded, produced with government money, it should be made available. But we just want to reinforce that and really institutionalize that particular perspective, no? Personally, for myself, with the way that our bureau right now, no, processes data in terms of surveillance, there are certain limits to us, to the extent that we can do more advanced analysis or more extensive analysis. So the value that I see in actually making this data publicly available is for researchers, no? To really further examine the data. And for us, it actually serves, it's actually beneficial for us, no? So what we cannot do, because of all other demands for data from us, that our partners in the academe and in other research institutions would be able to do that. Secondly, the longer-term system benefit is that it actually just develops broader health system capacity for analysis. And, you know, the end impact of that is positive for the health sector in general. Thank you.
Thank you.
If I may add, from the Disease Prevention and Control Bureau, also from the Department of Health, particularly with our division, the Partnership and Data Management Division, we also receive a lot of requests, no, for data from students and researchers. This is part of, as mentioned by Director Velasco, of the Freedom of Information. So we, what we do is we coordinate with the different offices within the Department of Health to answer or to respond to this data request. That's all. Thank you.
Thank you. It's really, I like the line of Dr. Velasco about really strengthening the capacity of everyone, because the data is there for our use, and if there's no data literacy, then the value of that data is very small in that sense. And you know, so much effort is actually done in collecting and documenting clinical care, birth registration, diba? What's all this effort at 99% if it's not gonna be used? So maybe I can ask our friends from DepEd, diba? How do you really prepare? What if in the locale there's an increase of, say, 10 births for that year? Ano po bang implication nun sa inyo? Yan. I was excited by what NEDA director, assistant director said about this should inform, diba? How many health workers you actually need, diba? The infrastructure that actually need. Maybe can I request members of the various stakeholders how you're actually using it in your own area, in addition to health Yan, baka po makapagbahagi kayo. I also hope to hear from our NCIP, the Indigenous Peoples Community. Lagi na lang natin naririnig na ang konti ng na record. So ano po ba yung mga ginagawa ninyo? What are you doing? So that perhaps, di ba, parang it strengthens our community resolve, this group of participants to be able to, contribute positively also to improving our systems. Yan. NCIP, Office of the Commission on Muslim Affairs. Yan, marami po kayo nandito. And even the local, baka po we can invite you to share also if you're actually using birth and death registration as you present your budgets to your own mayor. Yan. Now that the Mandanas ruling is here, are we taking advantage of this fully? Yeah. So that's a question to all the stakeholders, and I will call you again in a while. This is fair warning. Okay, parang school. Okay po. Okay, mahaba ang question. May I request Mr. Kenneth Mariano from Popcom to share and to present his questions already presented here. Sir Kenneth? Kenneth? He's online. Okay. Wow, phone in. Okay. Sir, ma'am, can I raise a concern to anyone from the PSA Region 12, particularly in North Cotabato and Sultan Kudarat, which just got hit by Typhoon Paeng, Tropical Storm Paeng. We've talked with the local chief executives of the affected municipalities, and they're relying on the data coming from PSA as basis for relief distribution and emergency response, only to find out that the number of households is incorrect, and especially it's kulang. So that affects much of the interventions being made, and more on their proactive planning. CRVS or CBMS, can we get more accurate data than this? Improve data collection strategies, involve more local during data gathering. Yan, tama. Diba? We are #1 in the World Risk Index in terms of, diba, our vulnerability to natural calamities. May I, Ma'am Al? Bitbitin mo nga yan. Hawakan nyo na lang po yung...
alam ko, may mga kwan dito, kasama kami din dito na PSA, na lalo na sa survey, sa mga households. May taga-population din dito na sila yung nag-gather ng censuses natin on census of population and housing. So, kasi yung civil registration is more on the CRVS data naman. Right. So, yung statistics on births, marriages, and deaths. While yung households na mention dito ay yung sa population census. Right. So, meron kami dito. Siguro si Sir nandito. Sir Region 12, si Sir Mac. Attorney Mac.
Our regional director,
regional director ng Region 12
of the Philippine Statistics Authority. So this is interesting, really. So we're trying to use the data for disaster risk management. Okay, Mike, please.
Thank you very much. I'm not sure of what is really the meaning of kulang ang data. We have released the results of the CPH of the 2020 census population housing since last year. Okay. So we have not received any complaint anyway about the data that we have released, that we have collected during the 2020 CPH. But I'd like to see kung ano yung basehan ng ating anong office yun? si Popcom, kung saan anong specific na data sinasabi niya kulang at hindi tama yung ating counts.
Yan. Sorry, malabo po. But RD, I think they're using the PSA data in order to provide the relief services during the response phase. And when they started matching that, kulang. Kunwari, I suppose, kunwari 12 yung households na dapat bigyan ng relief, 10 lang yung na-record ninyo. Yan. Or something. Baka po, that's how I understood the story.
I think we have to talk that at our level kasi our data is already released and it's official as was proclaimed by the President. So we stand by the count, but if there are evidence na sinasabi may discrepancy, kasi 2020 pa yon at sinasabi niya ngayon, 2022 na, maybe we can also look at we can evaluate yung claim. Pero so far, kung meron discrepancy, doon kami sa aming count, pero pwede naman nila gagamitin yung kanilang data kung meron silang basehan to come up with that, with their own data.
Right. Thank you po. I can imagine. Yes, sir. Hi, NS. Happy birthday.
Thank you. I would just like
Dr.
to
Celeste.
react now. Maybe the question should be focused more yung hindi sa household kundi population.
Yan. Okay.
Population. And 2020 conducted, of course, we have the growth rate. Of course, households increase. But if you look at it na sasabihin na yung isang area, ito yung number of households na nagki-claim. And then, ibangga mo yun sa result ng 2020. Tingnan mo yung average household size. Right. Maybe because that is giving of benefits, other families or households na iisa lang sila will tend to split themselves or misrepresent themselves as two households instead of one.
Right.
Thank you.
Interesting yun. Sige. Yes, ma'am. Si Ma'am Maris ba yun?
Good morning. I'm Dr. Sosa. I'm from the Association of Philippine Medical Colleges, and I'm also a practicing doctor in a private institution. So yes, we do a lot of data collection, and specifically for our organization, for example, for our hospital, we do a lot of data collection where we base our programs. For example, the adolescent birth rates are important for us to develop programs for adolescents. To improve infant mortality or to decrease infant mortality. So the data that we gathered in our place, for example, Cavite, may be not similar to the national data. Yeah. So there could be a discrepancy between the national data and ourselves. And so therefore, if we create programs, we're going to be basing it on what we are having in the local unit, as what you have stated regarding local planning. So with that being said, I would also say that there are organizations like, for example, the Philippine Pediatric Society. They collect a lot of data in relation to all children, infants, children, neonates, adolescents. And these data are also, I think, being passed, whether to the system or to the organization, for us to come up with a general program for the Philippines. Yeah. And I don't know my question will be, how is this communicated to the national level, if it is just an organization or if it's just a hospital, because we are going to be using this data in toto. It's not going to be just in one area, just one organization, or just one province. For us to be able to make all of this data very effective and very translatable to whatever programs we will be having. Thank you.
Thank you. Thank you, Doctor. Maybe hear from our DOH speakers.
It's probably two things na rin, ma'am, I would say, no? I think the longer term, more strategic approach actually to sharing data is through, well, right now what we're aiming for is the National Health Data Repository. That is one, but I would extend that even further, no? Because to have a repository is one thing. So meaning, for instance, if we can actually, if all the data that you have for right now, no? and is actually stored in that repository, that means it can be accessed nationally. That is one. I would extend it a bit further again. Preferably, it's within the context of a health information exchange. No, we want our systems to communicate kasi po with each other. May implications din po yun sa data collection. What that also means is we can actually significantly and substantially reduce mga duplicative na data collection efforts, no? Na mas streamline po siya. Meaning you've already collected data. So for instance, if I'm interested in collecting similar data, I don't need to do that anymore because I can access your data na po, no? Of course, may mga considerations for data privacy, etc., cyber security, etc., etc. That's the longer-term approach towards that end, no? That we can actually access your data. And parang simultaneously na rin kayo, I don't see why not that you would be able to access data that is being used by national. Of course, may certain considerations pa rin yun, no? That's the first thing. Secondly, going back again to what I talked about on communicating, no, sa mga relevant na decision makers. So that's another more proactive way, actually, in my view, no, of actually relaying all this information, especially if you want someone to make a decision. Diba? So that goes the same na rin, hindi lang po sa head ng facility ninyo. Baka you want to speak someone in the local, speak to the local chief executive, to someone in the regions, and then possibly even nationally. So those are two approaches po, no? Na this information is just generally available to people who need them. And then secondly, is just taking a more proactive approach to actually communicating the information.
Yeah. Dr. Quintana, would you like to add more? Okay, sige. So something to look forward to. There will, well, it's a new administration, and certainly a lot of energies are, reinvigorated. So we look forward to having that kind of better cooperation. Diba? Yun po yung language of our WHO yesterday, and the DOH has really spoken. We will really try to integrate more. Yan. So we look forward to the use of digital technologies can actually facilitate all of these things, no? Okay, nice. Gusto ko lang po balikan yung sana nasagot si Mr. Kenneth earlier on, no, na there are two things pala po, no? So parang data literacy, it's a long way to go, but certainly kapag disasters yan po yung frontline issues nila. How how they are responding. So baka pwedeng tignan din yon, and i-organize lang po yung paggamit. I think maybe DILG can also weigh in this area, because the PSA at the local tried to really use that data, pero syempre diba, parang the population, as DNS said earlier on, is different from the CRVS data. Diba? So talagang magiging komplikado siguro. Magiging komplikado, obviously, at that place. Yes, ma'am. Yeah.
There was a question regarding how do you use statistics in terms of disaster response. No? That's why I think it's very critical that we need to have a rapid rollout of the community-based monitoring system, because then it answers the inter-censal data gaps that we may have, no? That will address real-time needs for statistics, population data, and even the use of birth and death statistics as basis for your disaster mitigation activities.
Okay. Sige. Last question from the ground, from our participants online. Maricel, no more na? Okay. Yay! Last words from our speakers. Meron pa po ba kayong masasabi? And okay. So I think the challenge is really to use the data now. So we are happy that there is progress already in improving data collection, and there's already progress in looking into data quality, and it's been a long journey already. We're not quite there, di ba? Hindi pa po perfect, pero di ba, why wait for the perfect when there are actually gains now? And the challenge that is really emerging is how to use it and use it locally. Yan. And communication is key. So, and it's a long way towards that one. Let's all work together in the end, at the end of all of these. So, with that, a big round of applause to Ma'am Aurea Lalas, Dr. Quintana, Dr. Padilla, and Dr. Velasco. Yes. May I request Assistant Secretary Untalan to join us, as well as our birthday celebrant, DNS Celeste, to give the certificate of appreciation. Dr. Bersales, join ka pa. Yeah, again, this certificate of appreciation is awarded to our speakers and discussants as valuable resource speakers in this National CRVS Stakeholders Conference held on November 16, given this day at Bay Hotels in Cebu City, signed by Undersecretaries MAPA and Undersecretary David of the DOH and the PSA. Yan. For Chief Aurea Lalas, for Directors Sosteline Padilla of the NEDA Region 7, for Dr. May Velasco, Director of the NEB, and for Dr. Quintana of the DOH DCPB. Thank you. Mahaba yan. Okay. Lapit tayo. Okay, everybody please stand and have your coffee. There's going to be a bit of coffee break for 5 to 10 minutes. We'll call you.
We encourage everyone to get their coffee, stand up, move, and do some networking. But please be back on your seats at 11 o'clock. So you have 15 minutes for coffee and networking. Thank you.
Okay, we'll start a little earlier. May I request everybody to come in already and take your seats. Yan. Sige po. Tayo na po parang makarami dahil ang kape ay sufficient lang hanggang tanghalian para mas maaga ang ating tanghalian. Yan. Okay, hear ye. Please come back. Bring your coffee. We appreciate the smiles. Continue with the smiles until later. Keep it until the whole day. Okay. Sige po, magsisimula na tayo. Baon na po kayo ng inyong mga kape at tsaa. We will give you 1 more minute yan, to come and sit and take your seats. Sige, dahil marami talaga tayong pag-uusapan ngayon. Okay. To our esteemed DOH people. Thank you. Okay, everybody, tayo na po. Mamaya na tayo mag-picture din. We will invite everybody to have your picture here also. We have a nice stage mamaya. Okay. Tayo na po. Ding, ding, ding. Okay. Good morning, everybody. Okay. You can kiss your katabi. Di ba po, pag sa kasal, pwedeng halikan nung bride, nung groom yung bride niya. So, pero now, give a good smile to your katabi. Again, I remind you, don't forget your questions so that you can earn your lunch. Okay? So, you really have to weigh in. Maybe, habang inaantay natin maghanda ang ating speakers, for the stakeholders, can you please also pipe in how have you been using the CRVS data so that we increase the value, diba, of all of these data that we are collecting? Yay. So now let's proceed to session 5A and 5B, innovating to transform the CRVS and the information system. So we have 2 esteemed speakers, and we are blessed to celebrate his birthday today. The first speaker is Mr. Fred Saliesa, currently the head of such an important effort, the Philsius Registry Office of the PSA. He is an electrical engineer. Wow, sir. Parang PSA, ang daming engineers pala, and very critical, diba, and really looking forward. So he completed his bachelor degree in electrical engineering at the Western Institute of Technology in 1986 and a master's in business management in the same school in 2007. He attended the 18th batch of NSO PSA SRTC training in statistics and computers management in 1988 and has been regional director of the Philippine Statistics Authority since 2006. Our second speaker, linking EMRs or electronic medical records with civil registration information systems, is the chief of the eHealth Systems Division of the Knowledge Management and IT Service of the Department of Health. Ms. Cherry Esteban oversees end-to-end software development, security, integration, and interoperability of systems and projects of the Department of Health. She has almost 30 years of experience in systems analysis, software engineering, and deployment, and is part of the development of landmark disease registries and clinical systems within the DOH. She holds a bachelor's degree in computer science and a master's degree in management, majoring in public administration, and is a certified COBIT-5 assessor and an ITIL Foundation professional. Please welcome our first speaker, Mr. Mr. Fred Soliesta, currently our Deputy National Statistician, will then be followed by Ms. Cherry Esteban. Okay. Happy birthday, sir. Okay po.
Good morning, everyone. Thank you, Dr. Porcia. No? Today is my birthday. Tomorrow is the birthday of another Deputy National Statistician. And on Friday is the birthday of LSB. You know LSB? Lisa Grace Bersales. So, advance happy birthday to former NS Lisa. So, yes, of course. Thank you, Charity, no? Fellow Ilonggo. So, actually, this presentation on digitalization of the Philippine CRB system to improve processes and services, it is really the work of the civil registration system of service, I mean, of PSA, but ANS Maris requested me to present in behalf of the Civil Registration Service. Actually, a part of my tour of duty in PSA, after when I was the regional director from 2016 to 2019, is from 2019 to 2020, or around 18 months, I have my tour of duty as the officer in charge of the Civil Registration Service. No? So I also know by heart the processes within a CRS. So next slide, please. So the outline of my presentation would be first, of course, how the administrative arrangement of the CRBS system in the Philippines, and next, the overview of the current civil registration and vital statistics system, wherein what system PSA uses in generating, of course, our reports, especially on vital stat, including also the system we uses in the our frontline services or the copy issuance of civil registry documents. And our digital transformation journey from 2000 to present, no? Although digitalization maybe has been take a center stage during the last decade, but for PSA, formerly part of NSO, one of the agencies that constitute now the PSA, started even during the year 2000, the early 2000, at the time of Administrator Boots Africa. And of course, the last is the digitalization of the Philippine CRBS system, what we are currently doing, what is now in place, and what will be our vision of the future in terms of digitalization of the civil registration and vital statistics. So next slide. First, I would run through you the administrative arrangement of the Philippine CRBS. Of course, we all know that PSA is headed by the National Statistician and Civil Registrar General. So yesterday, I recall in the presentation of in the discussion of former Administrator Africa, the Philippines, nasa 15% siya ng mga countries na yung function, the civil registration function, is lodged in the office of the NSO. So National Statistical Office. If I may add, now because of the additional mandate of PSA, which is the PhilSys Registry Office, so PSA becomes more even more unique, no? Because the current trend now is really the suggestion at the global stage that civil registration and the national identification should be lodged in one office. Of course, the implementation arm of PSA in terms of the civil registration system is at the Civil Registration Service, headed by the an assistant national statistician. In the case of PSA, it is headed now by ANS Marisa Grande. And of course, directly under the Office of the Civil Registrar General, we have our RSSO, so the Regional Statistical Service Office for 17 administrative regions, and we have all the 86 provincial offices which takes care of the civil registration processes within the province. And doon nagre-report o nagsasubmit ng mga reports yung lahat ng civil registrars. No? So our linkage with the local government unit is to the Office of the Civil Registrar, the municipal and city civil registry office. Of course, we have the local health unit if it pertains to the preparation of the death certificate prior to the submission for registration at the LCRO. So next slide, please. So what is the current Philippine CRBS system? So we use the PhilCRIS, of the Philippine Civil Registration Information System. Actually, this is a quite old system. Unluckily, when it was developed, hindi siya yung parang, it was not geared na for updating because the source code was not properly turned over. So yun yung challenges ng PhilCRIS. But just the same, PhilCRIS really contributed a lot for all the stakeholders of the civil registration system, both in the private and the government in the private institutions. We have PhilCRIS for the civil registrars, and we have also PhilCRIS for institutions. So this is the flow of the documents, the data files coming from the local civil registry offices is forwarded to PSA provincial office, and ultimately it goes to the CRS, particularly sa CRMD, wherein it would be processed for the loading into the database for copy issuances, and a part of that being generated is the vital statistics, in which it is being encoded in the provincial offices and submitted to the vital stat division of the CRS. So the process is 10 days after the reference month, all the civil registry documents in all municipalities are submitted to all provincial offices, and we have around 6 weeks or equivalent to 42 days processing within the province, and then we have 45 days processing at the CRS. But now that we have the CRS ITP2, we have piloted, I think, at 10 provinces under the Vital Event Information System, in which 10 days after the receipt of the document at the CRS, it would be converted and ready for copy issuance, and at the same time, the encoding at the provincial office would be online. So we don't have to wait for this 42 days and 45 days processing time. So it would be really fast as soon as all provinces will be implementing. So next slide, please. So the digital transformation of the CRS 2002 present. It is anchored on a BOT project in the early 2000 between NSO then and Unisys Australia Limited. 12 years concession agreement. And when it expired, I think in 2012, it was extended in September 2015. It covers the establishment of 40 civil registration outlets nationwide. And imagine a digitization or conversion of more than 100 million civil registry documents. So before, to give you context, hindi pa siya digitized, you could see a lot of people, for those before who are familiar with NSO sa Santa Mesa, no? Araw-araw makita mo yan, daily ano yan, daily occurrence yan na mahaba yung pila. Sabi nga ni former Administrator Boots Africa, it really pains, no? Araw-araw nagre-report siya sa office, seeing those long queues. And really that gave birth na, yung ano ba, yung sabi na empathy, that gave birth na gawan talaga ng paraan kung paano siya ma-address yung digitalization. Kasi pag sinabi mo you are requesting for your birth certificate, pag sinabi mo na siya na ito yung date of birth mo, ito yung place, tingnan lang yan doon kung saan sa mga racks. Pag nakita na wala, negative. Pag nakita na mayroon, positive. Pero nung during na computerize na siya, di ba, lumabas na yung mga multiple registration. Because it is really very easy to process, to access yung mga documents na i-index na siya. O pag tinype mo lang yung pangalan ng ina, lalabas na yung mga record ng kanyang mga anak. So really, malaking bagay yung digitalization natin. And then, while CRS-ITP, it was the forerunner for CRS-ITP2, ito na yung during the time of NS-LISA na na-extend na part 2 ng ano siya, PPP project. But actually, kanina BOT siya, no, built on operate and transfer. Under CRS-ITP2, it is build, transfer, and operate. So may ownership kaagad yung ano, yung PSA, and then you allow the concessionaire to operate the project. So another 12 years development siya. Starting September 2016 until 2028. So, kung ako, yung nakikita ko by 2028, having the mandate, PSA having the mandate for the civil registration, the mandate for national identification, it would be really now a collocation of the CRS services and the PhilSys services for the Filipino people. So, pupunta ka doon, na isang center lang siya. You have the CRS outlets, you have the PhilSys registration center, and also caters to PhilSys-related services. So next slide, please. So yung what is the CRS-ITP and CRS-ITP1 accomplishments? So before, when we request for documents, wala pa yung computer, it would take months. Maybe you request for your copy of your birth certificate and security paper at PSA Central Office. So sometimes it takes not less than a month for you to receive kasi hahanapin, ipapadala. Now, with the establishments of 17 outlets, all regional outlets and selected provincial offices that has outlets, the CRS outlets. So in August 2022, yung ano namin, yung percentage of transaction, we could say that during that time we have 50%, no, yung increase niya ng transaction since August 2002, and in 2009 it goes down up even up to 95%. In the graph shown, the highest number of transactions occurred in 2018. Somewhat it dropped in 2019, and of course in 2020, 2021, and 2022, it decreased because of the pandemic. But through the years, you could see really the demand for civil registry documents. And many times in the past, that they say that the demand was because PSA directed that the use of the civil registry documents imposed on institution. It's the other way around. It was really the institution who see the leverage, who see the importance of using the civil registry documents issued by PSA. Alam mo kasi kung sa ano ka, kung sa local, no? I'm not saying na yung sa local, kasi sila yung source talaga, no? But during the time that all correction or changes in the civil registry documents would pass through a court process before correcting even a single letter or typo error, it becomes hard for the citizens and very costly for them to correct errors in the birth certificate because the records is not computerized. They just go to the adjacent municipality to register again. So it happens that in many cases, institutions, DFA, some other government agency, suffer from submission of second registration. But with the advent of the computerization, the CRS ITP2, we always issue the first registered documents. So doon na siya. Doon na yung ano, sabi ng ano, ang tagal-tagal ko na to, ginagamit yung aking na registration na to. Itong year, itong month. Bakit ngayon hindi na pwede? Dahil nakita na yung first registration. Yung sabi nga ng iba na 20 years na daw niya ginagamit yon, tapos bigla na lang hindi na ma-issue. So that means na after 20 years, siningil ka na pagpaparegister mo ng 2 beses. So yun yung ano natin na through computerization, we really issue the proper document in terms of the multiple registration, and we prevent delayed registration, yung double registration, because the civil registers will not allow any delayed registration without the presence of the negative certification coming from PSA. So yung conversion namin noon during the initial na rollout ng early 2000 ng mga outlets, medyo matagal pa siya because of connectivity issues. But over time, we improve, and ultimately in 1 to 2 hours, the document will be released. Now, it is even more faster considering that some of the outlets are now in CRS ITP2 having a different model in which we call that the hub and spoke, wherein centralized yung processing. We have the primary back office in East Avenue in Quezon City, and then the secondary back office in Cebu. So next slide. So this slide is a very powerful slide, no? Conversion of more than 187 million civil registry records into digital formats. So it started na yung yung archive na when we have the facility in Caloocan in Amparo, we call that the Jacala Warehouse, the name of the building. Before it was only one building, malaking warehouse siya. But after several years, maybe less than 10 years, it is now 5 warehouses. So malaki siya, no? And maybe sabi ko nga, after 50 years, baka subdivision na yan. So that is very important. Kahapon yung pinag-uusapan natin, yung amendment to the Civil Registry Law, the Omnibus Bill, must address digital archiving, or the archiving which we're doing now, in which hindi natin talaga na-dispose yung paper. And if you go around and look at the civil registry offices in municipalities, especially for small provinces or small cities or a small municipality, you could really see the problem in which a large portion of that office is being consumed by the records. And some of that, hindi pa nga siya secure, because of resource problem, which they become vulnerable in compliance to the Data Privacy Act. So dapat ma-address talaga yung archiving issues, no? And kahapon we have discussions that yung parang preparation na lang siya lahat ay na siya, digital. But if I also, I would like to weigh in also in yung fully digitalized na CRBS, in which in our country we have a lot of areas of people having no access to technology, na wala silang makuha na copy, no? And I think goal 2 of the decade for civil registration in VitalStat is about providing legal documentation on all civil registration events, birth, death, to ensure identity and ensuring rights of an individual. So maybe while we address the archiving, still a documentation should still be given to the registrant. That is why in the Philippines, compliant tayo sa Goal 2 ng CRBS Decade kasi yung napiprepare nga na document, 4 So a copy of that goes to the registrant. So yun lang yung sa digital, na full digitalization, wherein wala nang natatanggap na document yung registrant, maybe we could weigh in on that to really na make it na, kasi yung hindi naman issue ng archiving na binibigyan mo ng copy talaga during registration. So as of now, we have 187 million total civil registry records at the Jacala warehouse in Caloocan. So next slide. So this is the map of the location of the outlets in around the country. So during the CRS ITP1, we have 40, and as of now, we have added 10. The target really is 80. But under the provisions of the concession agreement, also local government units may opt, if they have resources, to have an LGU-operated outlet. So sila na yung gagastos ng lahat. And that would, for those interested, and as of now, many are interested to operate an outlet, it would really increase pa yung 80. No? Because if we have 86 provinces right now, including those in Metro Manila, kulang siya na hindi lahat ma-providean. But there are interested LGUs na gusto mag-operate ng outlet. So before ng ITP 140 and the full implementation of the CRS ITP2 in terms of providing outlets in key areas around the country will be 80. And I think towards the end of the year, may mga ma-open pa na outlet, and a sizable number will be added as per program in this project during the first quarter of 2023. And as of now, as I've said during my previous slides, that currently 10 provincial statistics office is using the Vital Event Information System. So what is good with this BEI system is this is an online encoding. So real-time siya, pumapasok sa data center. It really means a lot in providing faster and timely vital statistics report. Next slide, please. So we have the following QR code. You know, when you get a copy of your civil registry documents, the birth certificate, ngayon may barcode siya in, I think, 6 outlets in the initial rollout. So baka magtataka yung mga end users natin, DFA, and some other agencies na we issue birth certificate, yung isa may QR code, yung isa wala. Because that 6 outlets currently being piloted for the CRS ITP2 system, may barcode na yung output. And if you scan the barcode using that application, which is found in the Google Play for Apple and Android devices, you will see that the demographic information contains inside the barcode matches with those what is found in the document. So yun siya. Yung isang sabi ko nga hindi natin napag-isipan na sana in the design of the system, once a document is annotated, it would have a different look, no? Kung malilipat dyan yung parang barcode niya or yung annotation niya, kasi you know, Filipinos are very ingenious, no? Especially those who want to make a fake annotation in the civil registry documents. But I'm really impressed also of DFA na nakikita nila yon yung mga submission na mga documents na detect nila yung mga fake documents. Actually, yung may mga information diyan na like the brand is really about the number, the birth reference number. Unique yan for an individual. So madidecode mo siya kung ano yung mga characteristics ng demographic characteristics of an individual. So yun yung ko na nakita ko. Maybe CRS can later maybe make a change request to reinforce the security of annotated documents. So that's it. The application to scan the QR code found in the PSA birth certificate, in which is being implemented in 6 areas in the country. Next slide. And comparing CRS ITP1 and ITP2, over time, actually hindi nag-increase yung yung payment for CRS. The increase before from 125 to 155 is all about documentary stamp tax. And nakakasave pa nga yung BIR kasi walang physical na stamp na dinidikit yung doon, yung PSA, kundi printed na lang siya. And then we transfer the amount due for BIR. So what is added in for CRS ITP2, ito siya yung yung SINUDET, we have the certificate of no debt, we have the premium annotation to expedite. I think this is 5 days being implemented now at the East Avenue outlet. Wala pa siya sa ibang outlets. And then we have also the viewable online, na mabu-view mo lang siya online, mas cheaper siya, including those for Senomar and SINUDET, and also the doc print, no? I think yung doc print na yan ay part din ng viewable kung gusto mo pa siya i-print. One other feature that this is for release 1.0. For release 1.1, one good feature of the release 0.1, it would include the integrated government service point. What is integrated government service point? A government agency, for example, DFA, SSS, ito sila mga intensive users ng civil registry documents, PhilHealth, may interface their system with PSA. By interfacing their system, they could request from their system the issuance of the civil registry documents or even print at their agency the civil registry documents. So that can be arranged using the integrated government service points, which is part of the system under CRS ITP2 under release 1.1. Next slide. So this is just the ecosystem for the supply and demand of the PSA's CRS ITP2 infrastructure. We have a term called hub and spoke. So hub and spoke, generally, if you go to an outlet, they receive requests, but the processing is off-site. So what's good with the hub and spoke? Kasi centralized siya lahat ng nagpa-process. Unlike na ito siya, may maliit na outlet, the processors, mga 3 o 4 lang sila, pag may nag-absent na 1, 2, talagang mapipilay siya and then the release would be slower. But in hub and spoke, they are pooled. All the processors are pooled. I think in Cebu, close to 300 personnel are doing that now for the 6 outlets, including for the East Avenue outlet. And what's good with that, wala kang talagang na first in, first out, and then hindi siya ma-manipulate yung ipaprocess kasi hindi magkakilala yung tumatanggap ng request at saka yung nagpa-process. And efficiency-wise, hub and spoke is better. But for now, it is a combination of the current processes and the hub and spoke. Within the current process is may mga doon mo tinatanggap yung request sa outlet and then yung processing nandun din sa outlet. Of course, during the pandemic, especially during the pandemic, we accelerate really digital transactions, including the use of appointment system to limit the number of the people going into our office. So we have the GCash, we have the PayMaya, and also we have integrated decentralized copy annotation process within all the processes for annotating the RA 9048-101-72 is being done at the regional office. So next slide. Ano na lang daw, 1 minute. Oh. Pero kung 1 minute, medyo matagal yun. So for the digitalization of the CRBS system, of course, to improve our services to the clients, collaboration with civil registration partners, increase efficiency by improving processes, use of digital tools, and timeliness and accuracy of the release of vital stat. And to have an efficient processing of RA 9048 and 10172 if kahapon yung pinag-uusapan na mga online na siya na submission. Next. And then, component 1 for the CRB system, of course, the change in law or the omnibus bill, the component 2, the online platform for the e-filcris, or we are also looking at the open CRBS. Next slide. And component 3 about the digitalization of filing of petitions at the legal service. So next. So key features of digitalization, ito lang siya yung link namin, gusto namin i-link sa PhilSys. Yung isang, please give me a couple of minutes for this. Notification system, very important notification system. I see it as a notification system. Pag may notification system, pwede matingnan ni local civil registrar kung alam niya yung lahat ng occurrence ng vital events sa kanyang municipality, alam niya yung workload niya. Alam niya kung sa inong barangay, ilan yung mga pinanganak, especially community births and deaths. No problem with the facility. And of course, the linking of the CRBS and PhilSys, dapat makapture siya upon birth. And that would be, we will piggyback that in the e-filcris. Ano naman yung e-filcris ay pinapagamit ng PSA free of use sa lahat ng institution, of course subject to agreements under the MOA. We could use that to onboard yung enrollment ng mga newborn sa PhilSys. Yung problem kasi sa PhilSys, hindi siya compulsory, so we need really to have the consent of the parents and including doon yung information ng mga parents if they are already enrolled or registered sa PhilCris. Kasi kung wala lang sana, compulsory siya, abangan lang namin sa CRS at saka isid ng mga numbers and wala nang problema. But isa siya sa mga legal framework na problem na tinitingnan ng PhilSys in how to really link CRS and CRBS and national ID. Next slide. So ito siya, digital transformation. We have enhanced PhilCris for clinics, for the LCRO, including our Philippines Foreign Service Post, the notification system at the barangay level. We could use the barangay secretary, which is mandated under the local government code to help in the registration. Tutulong sila sa LCRO. And of course, the linking of PhilSys and CRBS at the CRS, and leveraging on the mandate of PSA with the mandate for civil registration in vital stat and the national identification. And of course, the transformation in the filing of petitions at the legal service under the Office of the Civil Registrar General. So next slide. So yun na, thank you.
Yes, we'll call on Ms. Cherry Esteban from our Department of Health. Yeah, there you go. Okay, isang masigabong palakpakan naman po kahit hindi niya birthday.
Good morning, everyone. Good morning. Gutom na po ba? Okay, last tranche for the morning. To the organizers, I thank you for inviting me. It's been an honor. My session is entitled Linking Electronic Medical Records with Civil Registration and Vital Statistics Information System. Somebody's operating it. Hi, Art. Okay. They say that when you make your commitment publicly, it becomes a reality. So today I'm sharing with you 3 important things that we believe we needed to get the ball rolling for this task. At the end of my presentation, I hope you understand why I'm saying this. First, I will share with you the overall goal of the EMR to the CRVS connectivity. Second, inform you with our strategy for interoperability based on our efforts in implementing the Integrated Health Information System as described in Republic Act 11223 or Universal Healthcare Act. And third, share key items to engage all players like hospitals and local government units for implementation. Before we move on, let me educate you of three important terms for understanding. First, what is an EMR? EMR stands for as electronic medical record. It is the digital equivalent of paper-based records on charts. More than 30 years ago, information managers transformed paper medical records and charts to electronic form to avoid the cumbersome handling of records. While this seems to be an old practice, it is one of the early forms of digitalization. Now we can see that an electronic medical record is any medical record, text or file that is stored electronically. On the other hand, health workers eventually realized that they need to analyze not only medical visits of a patient, rather all the patient's medical visit from different health facilities. As such, the term EHR or electronic health record was coined. We see that EHR contains all personal health information belonging to an individual, which refers his entire history across his lifetime. This includes data from multiple healthcare providers from a variety of healthcare settings. Essentially, an EHR could be a set of different EMRs and other information systems. And finally, we define what is an Integrated Health Information System, or IHIS. As defined in our policy with PhilHealth, IHIS is an integrated automated system that can process and communicate health and health-related data and reports. Essentially, an IHIS is a collection of both EMRs, EHRs, and other applications and technologies that health facilities may be using. To situate, I use this target ball to define the dimension of which one belongs to another. A set of EMR makes up an EHR, and EHR and other technologies makes up an IHIS. Now we will talk about goal in connecting EMRs as the smallest unit of technology to be connected to the whole of our CRVS technologies and systems. One of the items listed for actions of the WHO Civil Regulation and Vital Statistics Strategic Implementation Plan of 2021 to 2025 is to utilize digital advances for accelerating progress on vital event notification and cause of death assignment. The plan is very bold to state that this effort should be consistent with the international standards for interoperability, the development and adoption of the electronic health records, among other technology standard and technical standard. As such, we set the overall goal of EMR to CRVS connectivity as to improve timeliness and accuracy of CRVS data at the point of care, which is the EMR. We will do this by implementing internationally accepted clinical data and information standards under an agreed strategy from interoperability. This hopefully will meet the gap of lack of local civil registry offices in the country. Now we will hear the buzz, interoperability. I've been talking about interoperability for several times again, but what does it mean? Borrowing from the WHO definition, it basically, the core concept is that software, systems, and applications can exchange and make use of data in a standardized and systematic way. Interoperability has an important ingredient, that is standards. So there are different types of standards that are being defined in this document. Okay. Standards are a set of rules that allow information to be shared in a unified and consistent way. The types are, we have the technology standard, the data standard, and protocols and process. So how this concept apply to meet our goal? Let me share with you the story of Juana. Okay, so we'll read it all together. Juana is a 30-year-old Filipina. She became pregnant with her first child. During her first consult in a primary care facility, her primary care provider gave her access to her electronic record stored in an EMR. Her health records, validated through her PhilHealth ID, are neatly filed in the cloud, available for her and her healthcare provider team to access when needed. Juana's primary care provider keys in her information in an electronic medical record where all Juana's transactions are recorded. When she is about to give birth, her PCP referred her to the hospital for a facility-based delivery. The hospital updates Juana's record in their hospital EMR connected to the PCP EMR. The hospital took care of filing her child's birth certificate with the local civil register by connecting their EMR with the Philippines Civil Registration System, or PhilCRIS, and the Decentralized Vital Statistics System. Now I highlight to you 6 important events that determine how data and information is shared at the point of care and how birth registration could be connected directly in Juana's story. Number 1, the PCP uses EMR to key in Juana's PhilHealth ID number. Second, Juana's visit in the health facility is confirmed through the EMR and paid by PhilHealth. Third, the EMR retrieves information for Juana's consultation. Fourth, based on clinical guidelines, the PCP refers her to the hospital at the time of delivery. The hospital records Juana's information, clinical observation, make this available also with the PCP provider. Fifth, the hospital uses the EMR not only to encode Juana's health condition, but also files her for her child's certificate of live birth. And lastly, the local civil registry is able to get his information straight from the hospital through the EMR. This slide shows you the flows of information from the different actors in the story. When I say actors, they are not just persons, they are actually the health information technology actors. You could see this in diagram at the left side, the standards at which data flows. First, 4 have been defined by the health sector, with the last one is left to both of us at the DOH and PSA to plan out. The eHealth infrastructure that we are talking about is the upper right-hand side of this slide, would be the National Health Data Repository and its accompanying health information exchange platforms, which the DOH and PhilHealth is developing. At the moment, we have the Philippine Health Information Exchange Lite being implemented with the PhilHealth as part of the large eHealth infrastructure. This particular example ensures that primary care data is collected for and is paid for reimbursement. We will use this as our groundwork for the plans for EMR to CRVS connection. For this presentation, I summarize 3 policies related to UHC reforms in our health information systems as our foundational strategy for the interoperability we want to achieve. We can do this by understanding how the health system set the data standards, define the implementation model for IHIS, and check IHIS compliance and compatibility or capability. The DOH PhilHealth policy in the mandatory adoption of national health data standards for interoperability already defined the set of standardized health or health-related data, terminology, definition, and structure for exchange of data and information. These data standards are to be used in the implementation of IHIS. It is guided by the IHIS implementation model, which prescribes the stages on how our health facilities would move from implementing their EMRs, EHRs, and other technologies. At the stage 2 of the implementation model, the DOH and PhilHealth will assist all health facilities in developing their electronic medical record system. We will release interoperability profiles such as application program interface or APIs in a secured repository or website for our EMR providers to download to meet this required software or module at stage 2 implementation of IHIS. And to check if these interoperability profiles are followed, we have to check the EMR's compliance and capability through the Standard Conformance and Interoperability Validation Program, or SCIV. This program will organize a regional SCIV team composed of DOH, PhilHealth, and DICT counterparts who will perform EMR validation through a test site environment. This test site environment, much more like a website, is where applicants can test their application software if it meets our required data submission formats and processing. The DOH and PSA shall work together to define the standard connection of EMRs and CRVS system as part of the technical specification, which can be later shared to the EMR providers. Now let us put our context. In this slide, we have defined the standard data sets being collected for birth and death registration. We now have a system that can already generate. DOH has developed a system for hospitals wherein they can already generate the paper-based birth and death certificates. This is available in our system. Previously, these data are filled out separately in health facilities, which are duly submitted to local civil registry office. Since we have set the data standards already by policy, all we need to do is direct all EMRs in health facilities to encode birth and death data in correct format in the EMRs. However, complying to standard data format is one thing, so submitting and processing this data in CRVS is another. So following the IHIS implementation plan 1 showed earlier, we will develop with PSA an API technical framework, which is a description on how EMRs could connect to PhilCris. This is one of the possible interoperability profiles that could be developed and made available for use by the EMR providers and hospitals. At the regional level, we will check if the EMRs who follow the API's technical framework can submit data from their EMRs to PhilCris and DVSS. We can piggyback this requirement to our hospital licensing requirements, which says that all hospitals should have a fully functional EMR as part of their IHIS implementation model within the SCIV. This is no need to worry on delayed licensing requirements since SCIV testing results should have been available in the next 3 days. Once the SCIV is successful, we can say that the EMRs can submit data to CRVS system without the delays of paperwork. But following this process will not ensure us that we will be successful. So I now leave you 3 important points to ponder in engaging EMR players for the EMR to CRVS connectivity. Number 1, successful, we should prepare our e-health infrastructure, both DOH and PSA IT. Teams should plan on developing the API technical framework and test it in a sandbox before national deployment. It's not an easy task that you integrate 2 systems from different agencies, but if you have set the data standard that they need to comply, it's easier for the technical people to do that. Second, we should have a strong IT project management team that could respond to the gaps of our EMR and CRVS connection. DOH and PSA should be agile for all needs for improvement. So we should not be locked up with what we have, but instead we should collaborate more just to ensure we are integrated and interoperable. And number 3, the PSA should develop stimulus package for both health facilities and EMR as part of the incentivizing an option. At the end of the day, compliance to interoperability has software costs to be borne by health facilities and EMR providers. Though there are still health facilities that are self-sustainable, meaning they have their own information system that they deploy in their facility. That's no cost to their end. But engaging other third parties, that's where the cost will come in later on. With that, maraming salamat po.
Time check. Thank you, Ma'am Cherry. So, maraming aabangan in the next few years, no? And it really, parang all of these concerns will really have to be planned out very well. And it is really for our kids. And we have to do it right kasi magastos kung mali yung gagawin natin. Time check lang po because it's already 11:50, tama po ba, by your watch? I just want to, the suggestion is we'll have early lunch and then we'll have the discussants later on. Pwede ba? Yun. I'm seeing Mr. Art Onqueco from Pivotal Peak. Mr. Arizeta, sir, is it still okay for you to have that session? And Senior Vice President Jovi is already online. She's okay in the afternoon? Sige po. Patanong yan. Sige. We're hoping we can do that muna dahil wala naman tayong ano. Otherwise, if she's ready, maybe we'll listen just one brief comment from our SVP, Aragona. Yan. Sige, set up na po natin. So we're trying to be flexible with our schedule. Okay, at 1 p.m.? Or now na? Okay, sige. We'll just have this short comment from SVP Aragona of PhilHealth. So Ms. Jovita Aragona, or endearingly called Ma'am Jovi, graduated from UST with a degree of Bachelor of Science in Industrial Engineering, again, another engineer, and finished her master's in Information Systems from the UP Open University. She has over 27 years of experience in the field of IT and is at present the Senior Vice President assigned to special projects on the Universal Healthcare Enterprise Architecture and the National Health Data Repository of the PhilHealth. She is COVID-5 Foundation certified and TOGAF certified and received the International Corporate Digital Transformation Leader of the Year in 2018. And for the longest time, she was with the Department of Health, Knowledge Management and Information Technology Service, heading the Division on Systems and Software Development Division. Ms. Aragona is also an active member of the Asia eHealth Information Network and provides advice as well to other countries who are part of this organization. She was also a previous member of the WHO Digital Health Technology Advisory Group and a group of renowned experts brought together on digital health programs and policy and others in the healthcare ecosystem with focus on digital health. So let's listen from Manila, Ms. Jovi, Senior Vice President, Ms. Jovi, Engineer Jovi Aragona. Okay.
Yeah, Doc, can you hear me?
Opo, a little bit more.
A little bit more, so shout.
Sandali lang, ma'am. Sige, try natin pa uli. Oo.
Yeah. Can you hear me loud and clear, ma'am?
Okay po. No video. Ma'am,
no, I have a video.
Walang video si ma'am. Ayan, information technology fails us. Okay na? Ayan. Almost. Ma'am Jo, kailangan po ng video. Habang siniseta pa, more about Ma'am Jovi, kasi nahaba eh. She was also the key foundational member of the National eHealth Program and led various experts groups. And she was the principal author of the Philippine National eHealth Strategic Framework and Plan and Health Enterprise Architecture at the Department of Health, and to provide, sound strategies for the adoption and development of e-health in the country, as well as the roadmap to integrating systems and interoperability. Ready na? Okay, Ma'am Jovi, please welcome again. Take 2. Voice na lang. Yay. There, now we see you. Good morning po. Welcome again.
Yeah, good morning po again. So, is the sound okay na po?
Loud and clear. We also see your video.
Okay, but I will have to stop my video because of some internet issue here.
Okay. Sige po.
Okay, so,
ready na, ma'am.
Yeah, ready. Okay. So again, thank you, Mr. Fred Solovska and Ms. Cherry Esteban from PSA and DOHK MITS for that presentation. So to begin with, we know that digital technologies are really essential. These are essential component and enabler of a sustainable health systems and universal health coverage. The digital health interventions like the one that was presented by PSA and the Department of Health are part of a wider digital health system. Both agencies, again, PSA and DOH, have their digital health interventions and applications on how to address the challenges of their mandates, functions, and those that are mandated by the law, like the Republic Acts. PSA Component 2, as seen in the presentation, will develop an online platform. So that's the new PhilHealth Civil Registry Information System that will digitalize the CRVS from the sources. That is from the hospital, clinics, or healthcare facilities. There is also the V1.0 Digital Transformation Targets Initiatives 2022 to 2024 on the births and death for hospitals and clinics. Now the DOH, through Cherry, has talked about the standards and interoperability that will eventually enable the PSA digital applications to communicate with the DOH digital applications with the use of their electronic medical record. The standards definitely are the cornerstone of the e-health strategy implementation. Key concepts towards interoperability have been clearly presented by Ms. Cherry, as well as how this apply in a use case scenario, how is information shared, strategy for interoperability, and players or the actors for the implementation. In the spirit of the whole of government, the whole of system, and whole of society approach of the Universal Healthcare Act, the PSA and DOH has to come up with a more coordinated and synchronized architecture and timeline if the digital intervention will be lodged at the healthcare facilities or institution. So please, we will join also PhilHealth, because in the UHC section 31, the National Health Data Repository will serve as the central repository of all health and health-related data. So this architecture that I'm telling, this will now be the blueprint of all our processes, our data, our systems, and our technologies to help PSA, DOH, and again, include us, PhilHealth, to support the workflow and roles of peoples in the health system. So I have noticed that one of the things in the presentation is for PSA and DOH to have the API technical architecture or the framework, technical framework. But to further enable us to really have a clear direction prior to the API technology framework, we should craft our integrated architecture in the context of the PSA, DOH, and PhilHealth requirements. The strategy of having or moving towards a more coordinated and synchronized architecture and timeline will accelerate our national digital transformation and digitalization of government services for the achievement of the country's SDG by 2030. If the digital application of each agencies and offices will entail double entry or encoding of data and or different data standard, pain points are inevitable from the perspective of the patients or doctors. We need to move from the siloed digital health interventions with agencies, offices with their own platforms and enterprise architecture to a digital health intervention supported by an appropriate platform to facilitate health information exchange in the country. Let us mindful and continue to address or resolve the issues or challenges on data quality. We must follow accepted data standards and create measures to support the integrity and reliability of data being collected, processed, or stored in our digital health platform. With the CRVS enhancement of the EMR, and of course the PhilHealth National Health Data Repository, all public and private, national and local, will be submitting data to the National Health Data Repository. So this has been mentioned, the National Health Data Repository has been mentioned by Ma'am Ninita Velasco a while ago, and even Ma'am Cherry during her presentation. The reason why I'm mentioning this one, because this NHDR, EMR, and the CRVS or PSA must start already crafting the synchronized and coordinated architecture plans and ready our systems for a health information exchange and a unified business intelligence and analytics. So we have, VOH and PhilHealth actually have developed the NHDR framework, and we are using a use case approach or methodology in defining the processes as well as the scenarios and the models so that we can have a very good or stable implementation of our National Health Data Repository. Again, my key message is we know that we have our own applications like PSA, DOH, but we really have to strengthen more our coordination and collaboration because at the end of the line, we should be mindful of the different issues, especially the pain points that our implementers, our end users will be encountering during the operationalization of the system. So on that note, I would like to end my comments, views, suggestions as discussant of this session, and thank you too for this opportunity to be here discussing and commenting. Thank you. Thank you, everyone.
Yay. Thank you, SVP Aragona. So really coordinate and collaborate as the main process that we have to do. Okay, so yun, baunin po muna natin yun, bubusugin muna namin kayo, pero babalik po kayo ng alauna rito. And we will continue our rich discussions in order to further this collaborative process. So thank you, everybody. Thank you, SVP Aragona. We'll see you again soon. Yan. Kain po tayo. 1 o'clock po, aha. Lunch is already served, and I think we have 3 buffets ready for everybody.